This is Dr. Ahmed Basuni, the Assistant Professor of Radiodiagnosis and Interventional Radiology in Ain Shams University Hospitals, Cairo, Egypt. Our lecture today will be about the ankle ultrasound, the scanning technique, and the most common pathologies. This is a diagram demonstrating the bones of the foot and ankle, which are the tibia, the fibula, the talus, calcaneus, cuboid bone, and navicular bone, as well as the three cuneiforms, the metatarsals, and the phalanges. Regarding the examination of the ankle by ultrasound, we examine the joint anteriorly, posteriorly, medially, laterally, and it's very important not to forget the inferior aspect to assess the plantar fascia. Regarding the anterior examination, we see three tendons, which are the tibialis anterior that inserts into the medial cuneiform and first metatarsal. Then comes the extensor digitorum that inserts into the base of the distal phalanges of the second, third, fourth, and fifth digits. Then comes the extensor hallucis that inserts into the base of the distal phalanx of the big toe. Starting the examination of the anterior ankle, we start by the TS examination, where we see the three tendons. Medially is the tibialis anterior, the middle one is the extensor hallucis longus, and the lateral one is the extensor digitorum tendon. In case I've got mixed with the tendons, I can just trace this tendon, for example, till the foot. You'll find that it will split into four parts, inserting into the second, third, fourth, and fifth distal phalanges digits. Thus, this means that this is the extensor hallucis tendon. Say this tendon, I don't know which one is it. I can just follow it by the probe also till I see the insertion into the big toe. So this means that this is the extensor digitorum longus tendon. And by exclusion, the tibialis anterior is the medial one. Moreover, we can extend the examination to examine the anterior tibial artery and its venicomitans, as well as the accompanied deep peroneal nerve. Then we turn the probe into LS position to examine the anterior recess to check for effusion. The fluid can be seen in two places. One between the distal tibia and the talar dome, and the other is between the talar dome and the talar head. Moving on to the examination of the lateral ankle, there are two tendons, which are the peroneus longus, which inserts into the medial cuneiform and the base of the first metatarsal bone, and the peroneus brevis, which inserts into the base of the fifth metatarsal bone. So we start the examination behind the medial malleolus, and then we can follow the tendons. The one beside the bone is the peroneus brevis, so we can remember it by BB, bone brevis, and the outer one is the peroneus longus tendon. Also, we can follow this tendon till its insertion, where we can see its attachment at the base of the fifth metatarsal. Thus, this also helps us to distinguish the two tendons. The next step is to examine the anterior talofibular ligament. We put the probe at the anterior aspect of the lateral malleolus, keeping its orientation with the talus bone in order to see the talofibular ligament. More preferably, we can do an eversion of the leg to stretch the ligament in order to better visualize it. Then we examine the anterior tibiofibular ligament. Starting from the same position, we examine the anterior talofibular ligament. We just tilt the head of the probe towards the tibia till we see the anterior tibiofibular ligament. Another structure examined and the lateral aspect is the calcaneofibular ligament. Here we put the probe LS with its upper aspect at the inferior part of the lateral malleolus and its tail directed towards the calcaneus with slight clockwise manipulation. In neutral position, the ligament will be lax, so maybe it will be somehow difficult to examine it properly. We have to do a dorsiflexion just to stretch the ligament properly and do the proper examination. Here we see the peroneus brevis and peroneus longus tendons seen above it. Moving on to the examination of the medial ankle, we examine three tendons, which are the tibialis posterior, the flexor digitorum, and the flexor hallucis. The tibialis posterior tendon inserts into the navicular bone and medial cuneiform. The flexor digitorum tendon inserts into the base of the distal phalanges of the second, third, fourth, and fifth digits, while the flexor hallucis inserts into the base of the distal phalanx of the big toe. We start the examination by putting the probe behind the medial malleolus in TS orientation. Here we see two tendons, a big one and a smaller one. The big one is the tibialis posterior tendon, while the smaller one is the flexor digitorum tendon. This area is also known as the tarsal tunnel. So we've got to examine the neurovascular structures in this area beneath the retinaculum, which are the posterior tibial artery and its vena comitans, also the tibial nerve. Regarding the examination of the flexor hallucis longus tendon, as for the LS examination, the patient takes this position. We first put the probe LS to detect the Achilles tendon. Then by moving it a bit medially, another tendon will appear deeper to it, which is the flexor hallucis tendon. In TS position, we try to move the probe slightly upwards after examination of the tibialis posterior and the flexor digitorum to see the medial and lateral tibial tubercles where we can see the tendon seated between them. A much more easier way is that I just move the big toe. So the tendon which is moving is for sure the flexor hallucis, so I can easily just detect it and examine it properly. Then we examine the deltoid ligament by putting the probe LS at the inferior aspect of the medial malleolus and then move its tail from posterior to anterior to examine the components which are the tibio talar, the tibiocalcaneal, and the tibionavicular. Here is an example of the tibiocalcaneal ligament. Another one of the tibio-talar ligament with the tibialis posterior tendon seen above it. Another important structure to be examined at the medial aspect is the spring ligament. It consists of several components, which is the superior supromedial, the medioplantar, and the infroplantar components. However, the most important thing is to examine it properly, as an injury in this ligament may cause an acquired flat foot. We put the probe TS inferiorly to the medial malleolus with respect to the calcaneo-navicular orientation, where we can assess the ligament properly. Above it, we can see the tibialis posterior tendon. Posteriorly, we examine the Achilles tendon. The patient is asked to put his leg at the end of the bed at this position. The examination is done in LS and TS position. This is the appearance of the Achilles tendon in TS position, and this is the appearance in LS, showing the normal fibular pattern. Here is the Kegger fat pad. This is the place of the retrocalcaneal bursa. Also, there is a retro Achilles bursa seen at this aspect. The dark area seen at the end of the tendon is the artifact known as anisotropy. So we must examine the tendons properly at this insertional region to avoid this artifact and ensure the absence of any injuries. Inferiorly, we put the probe at the calcaneus so as we can examine the plantar fascia. Normally, we measure it at this site just before the insertion. Normally, it ranges between 2 to 4 millimeters. If there's any increase above this measurement with the presence of complaint, this goes with the plantar fasciitis. For sure, we must do a comparative study as these measurements can vary from one patient to another according to the patient's build. So moving on to the common pathologies. First is the Achilles tendinopathy. This is a normal appearance of the Achilles tendon in LS and TS view. Any abnormal thickening in the tendon or part of it, like this appearance in LS and this one in TS, is considered to be a tendinopathy. Also, increased Doppler signal may be noticed. Another pathology is the calcaneal bursitis. Also, we can see here retro Achilles bursitis. Regarding the Achilles tears, this is an example of a tendinopathic tendon with increased thickness, with a small partial thickness tear seen in its substance. This is an example of a full thickness tear of the Achilles tendon. It's very important to comment about the size of the tear and the content of the gap, whether it is fat or fluid. Moreover, we've got to mention the site of tear from the insertion of the Achilles tendon in the calcaneus bone. Well, this is an example of herniated fat at site of the tear. Notice here the echogenic fat insinuated between the retracted fibers of the torn tendon. Here is another example of a calcific tendinopathy with the calcific foci scattered along the course of the tendon. Another pathology is the enthesopathy, which is irregular ball formation seen at site of attachment of the tendon, which may be accompanied with tendinopathy at the insertional site. Also, here is a dorsal calcaneal spur. A pathology which is known as Haglund syndrome is to be mentioned at this point, where we can find a dorsal calcaneal spur with tendinopathy of the distal Achilles tendon and retrocalcaneal bursitis. This triad is known as the Haglund syndrome. Since the Achilles tendon does not have a tendon sheath, it sometimes may be surrounded by a fluid. So in this case, it will be termed as a paratendinosis and not a tenosynovitis, as the Achilles tendon does not have a tendon sheath. Another pathology which may be seen in the Achilles tendon is the xanthoma, which is a deposition of fat within the Achilles tendon. By imaging or ultrasound, it can mimic a partial thickness tear or focal tendinopathy, but the main differentiating point is the history, where the patient usually does not have any complaint or pain, but just he noticed that there is increase in size of the Achilles tendon. It is usually bilateral symmetrical, and this can help us just to differentiate it between this pathology and the focal or tendinopathy or tear. By far, the most common pathology seen regarding the tendons is the tenosynovitis, where we can find fluid surrounding the tendons, maybe thickened tendons, and increased vascularity on Doppler study. This is an example of a tendon rupture, where we can see a full thickness tear or rupture from the insertional site that leads to a retracted, thickened fibers of the tendon. Another type of tear seen at the ankle region is the split tear. Usually it occurs or affects the peroneal tendons due to subluxation of the tendons over the fibula. This subluxation leads to injury of the tendon, mostly the peroneus brevis tendon, which lies above the bone directly. So during examination, you can find apparently that there are three tendons, while the actual truth is that this is a split tear in the peroneus brevis tendon. Another complication that can be seen in this type of tear is that the peroneus longus tendon can jump into the site of the tear and be impacted inside, causing derangement of the tendon. This is a video to demonstrate this type of tear with derangement of the peroneus longus tendon within the split tear of the peroneus brevis. Another test that can be done is the peroneal tendon stress test, where we do dorsiflexion and eversion of the ankle. This helps us to detect any subluxation of the peroneal tendons. We notice here, after doing this maneuver, there is subluxation of the peroneal tendons that can be noticed also here. And this can lead to a split tear. The injuries regarding the anterior tibiofibular ligament or the anterior talofibular ligament are almost the same. As we can see here, there's a calcific focus denoting an old insult in this tendon or tear. Also increased thickness that can be go with chronic injuries or partial thickness tear. This is a comparative study where we see the normal site thickness and the abnormal thickened tendon due to chronic injury or partial thickness tear. This is an example for a spring ligament injury. Here we see that the ligament is redundant with fluid conduction seen at start of the tear. This is a more aggressive injury. Here we see there's more increased thickness of the tendon with areas of lost fibers, denoting a spring ligament injury. Regarding the deltoid ligament injury, it's not that common. However, these are some examples of its injury. Here we see loss of the normal fibers of the deltoid ligament with a hematoma seen replacing the torn fibers. This is another example where we see the tendon thickened with disruption of its distal fibers and increased vascularity. This is an example of a tarsal tunnel syndrome, where we can see cystic lesion seen and the tibial nerve seen above this lesion. On dynamic imaging, we notice that this cystic lesion just compresses the tibial nerve. Doppler study can help us to check the vascular structures in this region. As we see here, this is the nerve, and this is the cyst seen just posterior to it. This is an example of the normal plantar fascia where the thickness is about 2 to 4 millimeters. In cases of plantar fasciitis, we notice that there is marked increase in thickness above the 4 millimeters, and a comparative study can help us easily detect the difference and diagnose the case. Thank you very much.